Okay, so welcome everyone to another Gero competency training. Today we are doing chronic pain, medication misuse, and the older adult with Dr. Katie Drago. She's returning, and we're gonna do a little bit of a introduction into training etiquette and our CEU details, because you will be provided CEUs if you would like them, but you have to do a little bit of something. So we ask you to keep your mics muted, utilize chat for questions and comments, and we will try to answer those in real time throughout the presentation. You are going to receive 2 follow-up emails. One email that is with the slides, the link to the recording for this, and any other training materials, and a CEU survey. So that first email will come from us. The second email is going to come from Portland State University, and they do our evaluations of our trainings. So that is a second email that you'll get. You'll get those emails within the next 2 weeks. It usually takes us about a week before we send out our initial follow-up email. The recording is going to be posted to our OABHI YouTube channel. We have 27 trainings posted to our YouTube channel for people to find, and I think that's it for that. Just to give you an intro to the Older Adult Behavioral Health Initiative. So we were started in 2015, and we have 24 specialists across the state. This training today is brought to you by Jackson and Josephine County older adult specialists. And we work across the state on the county level with all of our community-based organizations and our agencies. And we work to do collaborations and coordination, build capacity, and we do free workforce trainings and community health and wellness promotions. And we also provide complex care consultations. So if you want to know more about those things, you can go to the website, OregonBHI.org, find a specialist in your county if you're not in Jackson or Josephine, and get lots of really good information. Let's see. Our upcoming trainings in the series, we're continuing. We only take, I believe, 2 months off a year. So you get 10 trainings a year. So the next one in June is with Nirmala Dar, talking around self-neglect in the older adult. And then in July, I'm going to be presenting on advanced care planning, and it's a little intro, but then a little deeper dive. So we'll talk about health equity and accessibility and different things like that as well. So I'm going to introduce our speaker today. So Dr. Katie Drago graduated from the University of Arkansas in 2011. Completed her residency in internal medicine in 2014 and a fellowship in geriatric medicine in 2015 at OHSU. She joined the OHSU Division of General Internal Medicine and Geriatrics in 2015 to develop and run the inpatient geriatric program. This program provides consultative geriatric care for hospitalized older adults in partnership with medical and surgical providers. She served as the medical director until 2021, and then she transitioned to the director of quality for inpatient geriatrics. She has left OHSU, and she is transitioning into a medical director role within Marquis, which is a post-acute long-term care organization in Oregon. So we are really excited to have you back, Dr. Drago, and I'm going to stop sharing so that you can share your presentation.
Marvelous. Well, I am so delighted and very honored to be back with you all again. This is always a delight. I also love to see so many people were able to make the time to join us today. That is just an incredible honor for me. So I hope that this time will be really valuable for everyone. So we are going to talk and spend the next hopefully about hour and a half or so. My goal is to leave a good chunk of time for discussion at the end. As Angela mentioned earlier, if you have questions that come up as I'm going through the material, please feel free to pop them into the chat. I may be on a roll, but Angela and Janine will be monitoring the chat, and they have promised me that they will interrupt me so that I can answer questions or address misunderstandings or misinformation in as close to real time as possible. So I also want to encourage people, if you need to like get up and use the bathroom or anything, please do so. I do try to repeat myself. So please take care of yourself while you're listening along. So we're going to dive into a great topic for the morning, which is chronic pain, medication misuse, and the older adult.
And
I
Dr.
do have
Drago,
some,
you want
oh,
to
yes.
enlarge your presentation for us?
Oh, I
Your
did.
screen, your smaller one.
Oh, okay. Let's try this again.
Perfect.
Better?
Yep.
Fantastic. Okay. It wouldn't be a virtual training if there wasn't some technical gremlins, correct? Um, so I do want to make you aware of some paid and unpaid roles that I do have. I don't have any relationship to industry, pharma, or otherwise. I do serve on 2 local Portland area nonprofit boards of directors. They're nonprofit organizations. I don't receive any financial compensation for those services, and they will not be mentioned in this session. I also have received funding, honorary compensation for time from the Institute for Healthcare Improvements, Age-Friendly Health Systems Initiative, which we will also not discuss. And I just got hired on as a consultant for the Oregon GWEP, which does teaching and training to help elevate the geriatrics knowledge of the workforce in Oregon, which we also will not discuss. So my opinions here are my opinions based on my training, my expertise, the evidence as it exists, but don't represent any other organization. So before the end of this session, I hope we're going to touch on and at least explore all of these areas. So explore a little bit of the experience of pain and how that can translate into the potential for medication misuse amongst older adults. Explore the behavioral manifestations of pain, especially amongst those that are communication and cognitively impaired. Um, and then dive in and talk very briefly, I promise, about some pharmacology, some very commonly used medications that are prescribed to older adults and their pluses and minuses. I know and am well aware that the vast majority of you are not prescribers. And so I guarantee you this talk is geared towards folks that are engaging with patients that may be taking these medications, but that you are not prescribing these medications. So please don't sleep through that section. I tried to make it as digestible as possible. And then talk about some elements of successful treatment planning as you're walking in hand with a person with chronic pain. So I want to start here and give Angela and Janine in the chat a little bit of a seizure. True or false, pain is a normal part of aging. Think about this for a moment. If you feel comfortable, pop a true or false or a, oh, I have no idea into the chat. It's really just a thought exercise to help get our juices flowing. When I say normal, I mean physiologically normal, like a body, just the machinery of a body. It will develop chronic pain over the course of a lifetime.
We're having about 50-50.
Okay, great. That's what I was hoping for. Technically, this is false. So our bodies change a lot as we get older, and there are particular patterns to that. And then, of course, we're all delicate snowflakes, and that every snowflake is different. And that is particularly true as we age. But the sort of expected physiological changes of aging, like gray hair and wrinkles, typically should not include physical pain. Now we know that just life is pain, and being a human being comes with some degree of physical, mental, and emotional pain, and that is true. But when we're talking about knees, hips, shoulders, backs, nerves, all of that, as we age, their pain really should not be considered like, oh yeah, that's just you, you're old. That is a really common folklore that, particularly in medicine, has been around forever. I got trained that way, but it is not true. What we know about pain and aging is that there is a significant overlap. The Venn diagram here is pretty significant. So, almost 2/3 of older adults in the community report living with some form of persistent pain. The most common source of persistent pain amongst older adults is actually joint, muscle, bone, and joint pain. It's arthritis. Um, but it runs the gamut. Sources of this persistent pain really do sort of comprise everything that you could possibly think of. When researchers have looked at subgroups of just those with cognitive impairment, those with cancer, the prevalence is about the same. Um, Only about a quarter of that group of older adults living with persistent pain ever receive any advice or guidance on non-drug treatments. So massage, acupuncture, therapeutic stretching, you name it. Only about a quarter ever hear or receive anything about non-drug treatment. And then about another quarter, somewhere between 17 and 30%, never even receive any drug therapy for their pain. And this is particularly true for those oldest old over the age of 85, which is the fastest growing demographic in the United States. Those living with cognitive impairment have a lower odds of receiving pharmacologic treatment. And then those in a nursing home or hospital environment that are being managed or treated with physical restraints, that too is a predictor of receiving less than necessary pharmacologic pain management. And when the research that exists on why this is the case comes sort of falls out with a few different themes. Number one is stoicism. And I'm sure all of us kind of resonate with this, that either we have seen clients or patients or even folks in our own family that clearly they're in some distress, but they're going to say, nope, I'm going to tough my way through this. This is particularly common with like the silent generation, the World War II generation. There is just a sort of cultural belief that you rub some dirt in it and you move on. There's also internalized aging amongst our older patients with belief that pain is just normal. I'm old now. This is what I have to deal with. And again, we know that is not true. And then ageism from healthcare professionals and folks kind of in their orbit as well. Like I said, I got trained by some of my teachers as like, well, of course, this person is 90 years old. What do you expect? Before we really explore some of our objectives a bit further, I want to kind of level set with the term cognitively and communication impaired patient. You're going to hear me use this quite a bit. This is a broad umbrella in my view. And so for the purposes of this discussion, this broad umbrella is going to include people living with dementia, with Parkinson's disease, those that have delirium or are in the throes of recovering from a severe delirium, other neurodegenerative diseases, traumatic brain injury, severe persistent mental illness, certain severe intellectual disabilities, aphasias, which is the inability to speak or form words, autism spectrum disorders, and more. You can probably think about clients or patients that you've seen over the years that like, yeah, they probably would fit in here too, even if I didn't mention their particular diagnosis. So for the purpose of our discussion today, take kind of a broader lens of the cognitively and communication impaired people. What's important about these people, even though these diagnoses can be very different in how they manifest and how they affect people's lives, but when we're talking about persistent pain, these patients experience the same degree of pain as their cognitively intact peers. So, with the same diagnosis, if it's arthritis of the spine, or it's a fracture, or it's cancer, um, there is no reason to think that the cognitively impaired person experiences any more or any less pain than the cognitively intact person. What's different about those two groups is their reporting ability. So the people with cognitive or communication challenges are going to present and manifest their discomfort in some different ways than we all got trained or were expecting to see. There's some really cool science that's coming out here, particularly in dementia, looking at some chronic pain syndromes related to some of these disorders. We know multiple sclerosis can actually come with a lot of sort of chronic pain related directly to MS lesions. We're seeing kind of similar evolving data in dementia that suggests that regardless of the different kinds of dementia, that the prevalence of people living with chronic pain in the different kinds of dementia, Alzheimer's disease, vascular, and mixed dementia, which are shown here, is about 50%. That's half of people. And it's really not any different when you break down Alzheimer's disease versus vascular versus more of a mixed picture. When we dive into Alzheimer's disease pathology in particular, there's some really cool evidence from recent years that the plaques, the little sort of gunk, cellular junk that accumulates in the brain and between the neurons that is characteristic of Alzheimer's disease, may actually itself cause inflammation, which then leads to a chronic pain syndrome through kind of unchecked inflammation in the brain. So we are learning so much that we don't know about this group of neurologically and behaviorally ill older adults. And so what we say here today may even be different 5 years and 10 years from now. Pain presentation in older adults can be very heterogeneous, meaning that two people with the same diagnoses, if we were to take their list of medical conditions and put them up next to each other, and if they were nearly identical, the way those two people actually wear the burden of pain from those conditions may look very different functionally and socially. And so I call this that exercise, a tale of two patients. The two women that you see here have the same list of diagnoses. They both have moderate stage osteoarthritis in both knees, so degenerative wear and tear arthritis. They both have osteoporosis or brittle bones, and they've had sort of squished vertebrae called compression fractures in their spine. Same level, same number, everything same. The woman on with the cane on the right-hand side here, she lives in her community. She lives in a private home. She walks with a cane. She's able to do all of her ADLs, and she's even able to exercise. She goes mall walking with friends a few times a week. The woman on the left-hand side is in a wheelchair, right? Because she needs a wheelchair to ambulate household distances. She needs hands-on help from a caregiver or care attendant for her daily ADLs. And so she lives in an adult family home and really is homebound, classically homebound. She can socialize with other folks in the facility, but she's really kind of largely on her own. And the only people she really engages with are the staff when they're caring for her. This is a very common experience, and this is a kind of hopefully a clear picture of what I mean when I say heterogeneity in the way people wear their diagnoses and different degrees of persistent pain. So what's important about that is that you cannot just look at a client form or intake or list of medical diagnoses and presume that you know exactly what impact the diagnoses are having on that person's life. Very different. Remember, we're all snowflakes. And so every snowflake is different. We're going to talk a little bit about pain assessment, if you're doing assessments, and also what you may expect to see if you're reading records or if you're talking with care facility staff or clinic staff or other sort of healthcare team members on behalf of your clients. This, I know, is very busy and it looks very medical. All for you non-clinicians out there, all you really need to know is that not all pain is created equal. There are different descriptors and different experiences of pain depending on where it's coming from. But pain can also be mixed in etiology, like cancer, like autoimmune conditions like rheumatoid arthritis and lupus and so on and so forth, and other kind of more complicated diagnoses. So when we as physicians and providers are trying to diagnose a sort of pain diagnosis or situation, we're often looking for these particular adjectives as we're talking to patients because we're trying to put people's symptoms into one or more of these boxes. In part because if we can categorize the pain here and figure out where it's coming from, it makes diagnosis easier and it sort of crosswalks over to different kinds of treatment. Some unique manifestations. Remember, cognitively impaired, cognitively and communication impaired older adults, they can still verbally report. So you may work with clients or patients that will come to you and say, yeah, it really hurts. And I don't know what's happening. Here's, I had a fall or I did this thing and then it started. They may be perfectly capable of verbally reporting, but you probably, guessing, have had a number of clients or patients over the years that may not be as able to verbally report, or their verbal report is a little vague or sort of not as clear as a cognitively intact peer. And so in those situations, we look towards these more sort of unique manifestations that are very, very common in older adults, especially those that are cognitively and communication impaired. So I bucket these into two separate buckets. One is the physical signs, the other is the behavioral signs. Physical signs includes everything from vital sign abnormalities. So persistent pain can actually cause variability and spikes in blood pressure and heart rate that we may pick up when we're doing vital signs at home or in the clinic. You may actually see them wear discomfort on their face with like a furrowed brow, clenched teeth. You may see it in their fists, either kind of clenching or guarding a particular area, holding an arm gently or holding a belly or holding a back. I particularly like to watch people walk because people with persistent pain in their kind of trunk or in their legs or in their back, you'll actually see them kind of in their walk look a little uncomfortable. The next time you go to the grocery store or you're out in public drugstore or something like that, just take a moment and look around and kind of watch people walk. You can actually learn or intuit a lot about how their health is just by how they walk. Falls may actually be a physical sign of underlying persistent pain, as with functional impairment and then unintended weight loss, because pain actually negatively affects appetite and the desire to eat, along with the ability to prepare food to eat. Behavioral signs include everything from restlessness, disrobing, detaching attached devices, if that's in a sort of institutional setting, or like a continuous glucose monitor and insulin pump, which can be bad. Other things that may even not be medical, but like attached to them, sort of fiddling or removing. Declining food and drink, declining routine activity or mobility, repeated calling out. So particularly in facility settings or folks that are really debilitated in their home, what we as geriatricians say is someone calling out, help me, is pain until proven otherwise. And I can tell you after years of working in the hospital, where I heard this repeatedly, it was overwhelmingly the number one cause of those repeated, like, help me, help me, help me. Even physical aggression, grabbing, scratching, can actually be signs of discomfort. So in our history, some important things that you all may be uh, with your clients, with your patients, you may hear is that older adults may not verbally talk about pain. You may not hear that word pain. You may hear other descriptors like ache or twinge or other colloquialisms. I did part of my medical training in the South at the University of Arkansas, and I used to hear all sorts of colloquialisms about like a stitch. I got a stitch. I'm from California, so a stitch to me means something very different than it does to someone living in rural Arkansas. And so I learned that like a stitch actually is sort of like a pinch, like a twinge, a stab, something like that. And so depending on where your person is coming from, they may use other kind of regional dialects or colloquialisms to just be on the lookout for. You always want to ask, how is this affecting your life? Because really that affects treatment, what we need to do, how aggressive we need to be, and what options we can talk about now as opposed to when we have things a little more stabilized. If it's not a new issue, if this is a person who's been living with persistent pain for years and years and years, has taken tried treatments, we always want to ask, what have you tried before? what worked for you, what didn't really work for you. Sometimes this can even clarify the likely source of the pain, because again, different types kind of respond differently to different treatments, but it also helps us not reinvent the wheel. So if you've got a client or a patient saying, oh my God, I've tried gabapentin and all the providers want to tell me is take your gabapentin, but it doesn't work for me, right? We need that information. And then I love, in addition to asking the person what their experience is like, is asking about the people in their orbit as well. So if you have the opportunity to talk to family members, caregivers, trusted people, people that are in this person's orbit, I'd like to turn to them and say, can you tell me what you have observed? What do you see that maybe the person isn't as focused on, or just isn't as attentive to? And then we always want to pursue a specific diagnosis. Chronic low back pain is a diagnosis that you will see everywhere. That is not a diagnosis, that's a symptom. A diagnosis is going to be osteoarthritis of the spine, degenerative disc disease, impinged nerves, all of that. And that diagnosis is important. So if you've got older adults that maybe have fallen through the cracks, for whatever reason, haven't gotten the benefit of a diagnosis, you all are in really good position to say, you know what, maybe it's time to go, think about going back to your doctor, think about bringing this up again, and then that coaching and support to actively pursue a diagnosis can actually be really helpful and empowering for your patients and clients. You may see this, particularly in folks living in more of an institutional environment or even like an adult foster or adult family home. This is an objective pain rating scale that nurses and folks in staff and institutional setting often use for cognitively impaired patients. It's called the Pain AD scale. The AD stands for Alzheimer's dementia, which is the population in which it was first developed and validated, but it's since been validated across the board for all sorts of cognitively and communication impaired patients. And you can see it basically takes those behavioral signs that are going to be much more common in people whose verbal reporting ability is not great. And then it actually stratifies them by severity. And this has all been well studied and evidence validated. But it takes all of those behavioral signs that we talked about a few slides ago, and basically lends some structure. So an observer, like a nurse or a caregiver or a CNA, could actually kind of score how intense are these behavioral signs. Higher score, more pain. And this is something you can track over time as well. So if you're looking through records, if you're meeting someone for the first time and you see this pain AD scale, now you know what it is, but you can also kind of look to see numbers over time. Are we getting worse? Are we getting better? Are things just sort of hanging out and staying the same? Other signs of discomfort include what I've borrowed from schizophrenia, the negative behavioral signs. So social isolation, withdrawal from beloved activities, from hobbies. I don't want to do that. Pushing back the food plate, right? Like, no, I don't want that. Declining fluids, even some daytime fatigue and sleepiness, just that sort of powered down look can actually be signs of persistent pain. Particularly that daytime fatigue and sleepiness, sometimes we see that as a compensatory strategy. Pain actively interferes with sleep, particularly chronic pain, and particularly interferes with REM sleep and restorative sleep. And so if people are sleeping at night, but they're not really getting great restorative sleep, their brain is going to grab as much REM sleep as possible whenever it can. And that it probably is going to occur during the day. And so daytime fatigue, daytime sleepiness, napping more than normal can be a sign of uncontrolled or poorly controlled pain that's interfering with sleep. What's key here is that if you're working with a client, you've known someone for a while, or you're new to someone's case, any behavioral change, whether it's sort of positive, meaning aggression, acting out, verbalizing, right? Something new, or these sort of negative signs of someone just sort of dropping out, right? Apathetic, withdrawn, isolating. Any behavioral change should at least prompt us to be thinking, could this be something physical? Could this be undertreated or unrecognized pain from a new or existing diagnosis? If we don't think about it, chances are we'll miss it in this population. And that's really horrible. That means people are suffering when they don't really have to. Use all the opportunities you can to capture some assessments and observations of other disciplines. So family, in-home caregivers, part-time folks, neighbors. I even had a patient years ago whose closest confidant was his bartender. And in the hospital, we actually called the bartender and we're like, hey, what's been going on with this guy? And he was really helpful and said, I've known this guy for like 30 years. And he used to be this way, and now things are changing. And so don't be shy when it comes to those people that may be in your patient or client's orbit. For people who are algorithmically driven, and for whom this is useful, this is a really nice algorithm from the Department of Nursing at the University of Iowa that was published a few years, wow, 10 years ago now. That's a really nice step-by-step focused pain assessment. And what I like about it is that it splits up the steps into those that are cognitively intact and or verbally able to self-report. So those with intact verbal reporting ability, and those that really aren't able to do that anymore or have a more significant degree of cognitive impairment. And so again, for those who are really algorithmically driven, this is just a nice reminder of the things to think about and steps to take. What I really appreciate too about this algorithm is that these steps here really for everyone focus on function. You'll see in a moment that there is no perfect treatment for chronic pain. There is no silver bullet. The only, in the best cases with pharmacologic therapy, medication therapy, we only get a maximum of about 30% reduction in the intensity and severity of pain. So there's no silver bullet. What we're going for is as much restoration and preservation of function, and that includes sleep, emotional and mental wellness, and social function. Okay. I actually want to check in. Angela, Janine, are there questions or things in the chat that you think we should
No
tackle?
questions
There are
at the
not,
moment.
but
Okay,
I
great.
do actually have a request.
Oh,
So
yeah.
we accidentally gave out a link that is attached to Angela Jensen's name. So we have about 13 people who are showing up as Angela Jensen. And if you do not rename yourself to your actual name, I won't be able to give you CEUs because I have to be able to see who you are and how long you've been in the training. So please, if you need help renaming yourself, message myself or Janine, but I need you to, yeah, change your name. Awesome. Thank you, Katie.
Again, it would not be a virtual training if there
I
weren't a few
know.
technical
Little
gremlins, right?
hiccups. Yep.
Well, wonderful. This is also a nice reminder too that if I'm going too fast, if you have questions or things that just don't make sense, please pop them in the chat and Angela and Janine will graciously interrupt me. So we're going to shift gears a little bit and talk about treatment. Where I really like to start when I think about treating anything, truly, is what are we hoping to achieve? What is our North Star? And with pain, particularly chronic pain and persistent pain, it's about function. It's not about elimination of physical discomfort. Because again, there's no pharmacologic or non-pharmacologic regimen or cocktail thereof that, at least based on the evidence and the science that's out there, that can be expected to completely eliminate all physical discomfort. Actually, I take that back. There's one medication regimen that does that, and it's called general anesthesia. Everything else, we can expect partial improvement in the intensity and severity of pain. So really what we're shooting for is a restoration or preservation of as much physical, cognitive, emotional, and social function as possible. So that's what we want to track over time. As we're making goals and as you're setting really discrete, actionable goals with your clients, I encourage you to focus on tasks and focus on function. So, really common goals when we're treating chronic pain are things like I want to be able to stand at the kitchen counter and prepare a meal for myself tolerably. That is doable, right? That is an actionable goal that we can work towards when we're talking about treatment, cocktails of different treatments. Of course, we always want to enhance comfort, but again, the only medication regimen in the world that provides 100% comfort and 0% pain is general anesthesia, and that is just generally not consistent with living life. We want to target as much as possible the source of the pain. So again, the diagnosis and the type of pain that I mentioned earlier, to patient goals and also to the treatments, right? So we want everything as much as possible to kind of nicely align instead of just kind of shooting spaghetti at the wall, which does happen at times. And then, of course, we always want to minimize the side effects of medications. Older adult bodies are just different when it comes to taking pills and taking different treatments. We'll talk about that in a moment, but they're much more vulnerable to some of the untoward or unanticipated side effects and consequences of a whole bajillion different medications. And so, as we're treating pain with sometimes some high risk combinations or high risk agents, we really want to be cautious about alignment as much as possible, focusing on achievable functional goals while also minimizing those side effects of medications. I've referenced this already, but I'm going to say it again because I feel like there's no degree of repetition here that's bad. There is no medication or combination of medications that is consistent with being awake and living your life that can be expected to completely eliminate chronic pain, period. It doesn't happen. We know from neuroscience too that just the experience of living with chronic pain actually rewires different parts of the brain. So chronic pain kind of perpetuates itself over time, particularly people have lived with chronic pain for a number of years. And so that too just makes it completely improbable and unlikely that there's any cocktail of things, drug and non-drug treatment, that is going to completely eliminate all of that discomfort. Again, our goal here is functional. So we want to pick out things like what are the activities, the tasks, the social things that we want to do, and then also allow some space for any sort of concurrent depression, other medical treatments, other mental health treatments to reach their full benefit. If we can turn down the volume on the pain, then it actually allows things like antidepressant therapy and other depression treatments, as an example, to work better.
We do have a question in the chat.
Good, great.
It says, how do you combat doctors that are resistant to searching for further answers or diagnosis and will not change pain medications? As I have a client currently that is in chronic pain and is not able or willing to participate in PT, as the pain is limiting her ability to do daily tasks or go out in the community.
That sounds miserable. Number one, I'm sorry. Doctors are stodgy types, and we can be very, very stubborn and not all that communicative. I say that in betrayal of my people. But persistence pays off. So, and I hear from my therapist all the time that she calls doctors and she's like, I can never get anyone on the phone. I understand that. That is real. You may not be able to get the physician or the provider on the phone and directly talk to them, although you should not stop trying to do that. But you may actually have more success if you ask to speak to the RN that works with them, or the medical assistant or LPN or whomever is sort of on their team. They may actually have a little more time to talk with you about patients. If the patient has a care manager through primary care or specialty care clinic, I would also want to talk to that person because sometimes it's the messenger. So for a physician or provider to hear from a county caseworker or mental health specialist, they may sort of be like, who is this person? What is going on here. Um, we get a lot of unwanted, unsolicited calls from like insurance care managers and like mail order pharmacy care managers that were like, what the what? Who are you? Do you even know my patient? So it may just be kind of a bias towards like, I don't know you, I don't trust you. So if you can work the team, the rest of the primary care, like medical home team or the specialty team, through the nurses, through the MAs, the care managers, even the social workers, sometimes if they deliver the message that like, hey, this poor person is not able to do their PT, can we get them back in here and think about something else? Sometimes that will work. So use all of your kind of benevolent manipulation skills to sort of work the team that is involved in this patient's care. Sometimes it's the messenger, and sometimes it's persistence. That is not an easy question to answer. Shoot me some easy, like softballs. Um, Thank you for putting that question in the chat, though. That is a huge, huge, huge issue. I wish I had the perfect answer to that, but unfortunately, it's just going to be kind of trial and error and, again, benevolent manipulation. Coming back, I also want to just sort of uh, spark the wire in all of our brain that pain, particularly pain in the absence of an easy diagnosis or a clear, maybe not easy, clear diagnosis, should prompt us, not right away, but also should prompt us to think, I wonder if this is sort of chronic aches and pains of depression and anxiety. Full disclosure, I go to therapy. I have a wonderful counselor. I have dealt with depression, and one of my depression symptoms is headaches. And I know that now, but I also remember having a lot of aches and pains in my body that as soon as I actually got the depression under good control, those went away. So this is certainly true of older adults as well. You also may see sort of vague, difficult to pin down pain as a sign of persistent stress, particularly if your client's a caregiver or has a complicated family dynamic, as so many of us do. May reflect some unmet structural health needs like food insecurity and things like vitamin deficiencies and such, which can also contribute to physical issues, and then may also be a driver of substance use, which we'll talk about a bit later. I mentioned this earlier, but older bodies process drugs differently than our younger adult counterparts. Some of you might be looking at this and thinking, oh my God, I did not sign up for this. And you're right, you did not sign up for this. All you need to know here is that older bodies absorb, process, and eliminate medications and supplements very different from younger bodies. Okay, it's just true. You don't need to know any more of the details. That's why I get paid the big bucks. But you, as you're working with clients and maybe aware, um, can even inform your clients that like, hey, I know that older bodies, a liver that is 80 years old is going to work differently than a liver that is 35 years old. Um, and that has impact for dosing of medication. It's also going to make certain medications a bit riskier in older adults, and then some others very, very effective at like teeny tiny doses, which seems very strange. And a lot of even my physician colleagues and provider colleagues may not know this. We're trying, and there's a lot of effort statewide to help providers prescribe a bit more thoughtfully for older adults, but there's still a lot of knowledge and a long way to go. These are the general rules that we tell prescribers, just so you know what they're hearing, that are sort of the big time rules for prescribing any medication to older adults. We start with the low doses and we go up. We try to advise people very hard not to start with like the 20, 30, or 40-year-old dose. Start with the 80-year-old dose because you can always add if you need to. Harder to give someone like a whopping dose of a muscle relaxant or gabapentin and then be like, oh, that was too much, right? Those are really hard situations. We try to start and stop one medication at a time so we can sort of see what is the impact. If we're starting 2 or 3 meds at a time and someone has a side effect or a complication, then we have no idea which one that was related to. There's an art to prescribing as well. So we try to streamline. So where we can use one medication to treat several diagnoses, we love to do that. This is particularly common with antidepressants. So, because so many, particularly of the SNRIs, like duloxetine, like venlafaxine, and others, are used to treat different forms of chronic pain. So, if there is concurrent depression and particular forms of chronic pain, we love using SNRIs. So, you may see clients or patients that are receiving that kind of therapy. We, again, start low, go slow, older liver, older kidney, not the same as a younger liver or younger kidney. We try to avoid prescribing medications for side effects of other medications because that is just a way to get in this horrible death spiral. And then even if people are being treated with medications, you can still get some really good benefit out of non-medical therapy. So even if you've got folks that are on chronic opioids, which we'll talk about in a moment, they may really benefit from regular Tai Chi or massage or low-cost acupuncture, even if they're on opioid therapy.
Dr. Drago, there is a
Yes,
question.
great.
Yes. Sorry, let me. How much is dietary change prescriptions being used for chronic pain management?
Ooh, boy. That is a very, very good question, and one that I don't think has sort of reached its prime time yet. And what I mean about that is that there is not much literature, at least in sort of traditional Western medicine, randomized controlled trials and all that Western science about different diets specifically for chronic pain. So my answer to that is we just don't know. Like we don't know if there really is a chronic pain diet, quote unquote. Um, I know culturally, in Eastern medicine, there is a lot more kind of understanding about the potential benefits of different sort of macronutrients, micronutrients, so on and so forth. I am not an Eastern medicine practitioner, so I don't feel comfortable speaking to that. But my hope certainly is that, and I do see some signs of this, that there is a lot more interest scientifically in understanding what is the relationship between diet and chronic pain, especially with some of the new revelations about ultra processed foods and maybe some of the systemic inflammation that comes from that. I think there's going to be a lot more about this over the years. That said, I had a great, great, great patient that I will never forget, and I hope she's doing very well from when I was a resident, who is a young woman in her 30s who was just debilitated, had a fibromyalgia diagnosis, and debilitated by sort of myofascial pain all over her body. She was a runner. She had to stop running. It was horrible. She at the time was able to see a nurse practitioner at the Frida Center, which was used to be a fibromyalgia specialty practice in Portland years ago, who did some testing, and I wish I knew what it was. I was never able to find out, and determined that she actually had a glutamate allergy or intolerance. And she went on a low glutamate diet, and almost all of her myofascial pain resolved. And she was able to run again. In fact, I used to see her for running related injuries like piriformis syndrome and such. So I am a believer that there may be some truth. The science is just not mature enough yet. That said, all the basic rules apply. So older adults really should be eating lots of protein, kind of a protein forward diet. The Mediterranean diet is a really, really good general diet to follow, even for folks that are receiving SNAP benefits and other such supports. Like there is a way to do Mediterranean diet on the cheap. And there's a lot of great cookbooks and online resources now that are open source for how to sort of stick to a Mediterranean diet. So I do feel comfortable saying focus on what we do know and just expect that we may learn more over the next years.
Thank
I hope
you.
that answered the question.
That was great. That was a great response. There's one other question. Amber is
Awesome.
asking, could those SSRIs be used to help with all types of pain?
Good question. So SNRIs have FDA approval for particularly duloxetine. That's the one that has the sort of clearest evidence and FDA approval. We do tend to use venlafaxine as sort of an off-label duloxetine on the pretty clear presumption that it's a class effect, not just a duloxetine effect. The FDA, I believe, has approved these medications for chronic musculoskeletal pain, so particularly joint related issues, chronic muscular issues, and then also diabetic neuropathy, diabetic sensory neuropathy. Those are the FDA approvals. All that means is that that's where the evidence is the clearest and the strongest. That said, in real world practice, you will see these medications, duloxetine, now that it's generic, venlafaxine, all the rest, you will see them prescribed for all sorts of persistent pain. So they are really, really commonly used off label. And it's kind of a mixed bag. For some patients, it really helps. And then for others, it really doesn't. And it's hard to say why that is, just because we don't have great science and a lot of this is off-label use. That said, if I've got a person sitting in front of me that is dealing with really intertwined depression and persistent pain from whatever cause, I'm probably going to reach for an SNRI. I have prescribed them off-label and seen them really work for some patients. That the co-occurrence and the intertwining of both of those conditions is often a good enough reason for me to reach for one of those agents like duloxetine. And I think most providers, family medicine, primary care, internal medicine, I think most of us are practicing that way. It's not a specialty geriatrics thing. All right.
Great.
Other question?
No other questions. Thank you. Not at this.
Cool. All right, let's get into my favorite part of the talk, which is bashing medications. Muscle relaxants. I've listed some of the names that you might see or hear about from your clients. These are all muscle relaxants, all of them. That's how they're used. Diazepam and baclofen are used for other conditions as well. But really, all of these are different kinds of muscle relaxants. These only ever had evidence for short-term use after, say, injuries. Baclofen is a little different because we do use it in spinal cord injury for spasticity and MS for spastic sort of MS flares. But the rest of them, there has never, ever been any evidence or any science looking at chronic use of these, which does tend to happen with methocarbamol, tizanidine, and cyclobenzaprine, which is Flexeril is the brand name for cyclobenzaprine. So know that whenever you see someone who's been taking them like off and on, even for years, there is no evidence for that. And here's why, because these are highly, highly, highly anticholinergic medications. What that means is that they have a particular action on a particular receptor, the chemical receptor in the brain, that will cause, it's almost a guarantee for older adults, it will cause the side effects that are listed here: sedation, lethargy, blahs, highly, highly implicated in falls. So when I was working at OHSU, I used to see a ton of older adults come to the hospital after a fall with an injury, a brain injury, a fracture, a something else, in part because they were taking cyclobenzaprine. That's my favorite to hate on. They can also cause headaches. They can cause blurry vision. They can also be dependent. They can trigger dependency and withdrawal. Several are on a list of medications that geriatricians recommend not prescribing, called the Beers list. And so we really just say these are a no. They really do not have a great use. They have almost no evidence for use amongst older adults, period. And yet they are highly, highly, highly prescribed to older adults. And so we typically say absolutely not, period. Instead, if people are having like muscle spasms, say with lots of back pain or around an arthritic joint or something, instead there are better options. A heating pad or an ice pack can actually be very effective for those types of symptoms. Even some topical agents like topical Voltaren gel with a V, which you can buy now over the counter at Fred Meyer, at Walgreens, at CVS. It's a topical ibuprofen cream that just stays right where you put it. It doesn't get systemically absorbed because a lot of older adults cannot take ibuprofen. Those are going to be much more favorable for people having lots of muscle spasms or achy tight muscles than a muscle relaxant. So if you've got a client who is taking one of these muscle relaxants and you see they fell a while back, they're telling me like something just seems kind of wrong. This is a flag to raise to maybe not the provider, maybe the folks on their team to say like, hey, I am worried about this. You may not have heard this, but like, this doesn't look good. So what about opioids? You've heard me mention chronic opioid therapy before. I want to reiterate, this is my opinion. This opinion is shared by a lot of other geriatricians in Oregon that do treat older adults that are living with chronic pain. And so our approach to this is that opioids should always be considered on the table. So I very rarely consider for any particular person, they cannot receive any opioid therapy. There will always be particular and specific older patients that are going to benefit from the regular use of an opioid, a judiciously dosed, appropriately managed opioid. Okay. And I've put the graphic here because this really is the Goldilocks problem, right? The Goldilocks, the porridge was too hot, the porridge was too cold, the porridge was just right. That's really the paradigm for chronic opioid therapy, is that for some people, it's going to be too hot or too cold, right? Maybe folks with a prior or even active opioid use disorder. We really shouldn't be faffing around with chronic opioid therapy. But you are going to see some people for whom that may even be the best option.
Well,
There,
there's one comment,
yes,
if I could please.
yes.
Vicky has just suggested that Voltaren packaging advised not to use over the age of 80.
Oh my gosh, really? Oh, that is disappointing. So, I can tell you, as someone who regularly hangs with folks over the age of 80, we do not have a significant worry at all about topical Voltaren for folks of any age. I mean, I've prescribed it to 100-year-olds. It's more about appropriate use. Now, we do not ever want anyone slathering their entire body in Voltaren, right? It should be used right where it hurts. I use it when my knuckles start to bother me. I'm a knitter, so when I knit for too long, they start to bother me. I had a rotator cuff injury. It's really good for rotator cuff injuries. So nobody should be slathering themselves in it, but the appropriate use for folks at any age, evidence has suggested that it is completely appropriate. So I'm really disappointed. I had not realized that.
Vicky says thank you. And then Tara has asked, what is your opinion of prescription compounded medications that are applied to the skin? For example, baclofen magnesium mix.
Holy moly. So compounded salves like that can actually be beneficial. It really depends on what's in them. So a topical baclofen worries me because there is, even though you put stuff on the skin, every topical medication is going to have a slightly different degree of absorption into the body and into the bloodstream. We know that Voltaren really doesn't penetrate into the bloodstream all that easily when it's topical. So for that reason, even like kidney doctors will give it to their patients on dialysis that couldn't take ibuprofen by mouth, but because the absorption is just so minimal, they can take it topically. baclofen worries me a little bit more. I would want to know more about how the person kind of earned that therapy, quote unquote. It's possible that maybe they were taking oral baclofen and it worked for them, but it became a little more risky, and so they tried topical instead. I could understand that. But yeah, I'd want to know more. That would worry me a bit.
Thank you.
Yeah, of course. Thank you for these questions and comments. I think this is awesome. You guys are really challenging me, so I appreciate that. Coming back to opioids, there is still a very prevalent fear amongst the prescribing community about prescribing opioids to older adults. I was trained, I am not that old, and I was trained that we never should give opioids to anyone over the age of like 50. And I went to medical school from 2007 to 2011. So right at the very beginning of or kind of the big awareness of the opioid crisis. And so that fear that was always there, even back in the 90s and long before, just got supercharged in the mid 2000s, particularly when it came to older adults. But what we have learned since then is the same lesson that we've learned before, which is that withholding opioids when they're indicated, so again, for the right patient with the right condition, folks that are trying to recover from a surgery, folks that are trying to recover from a major injury, even the appropriate person for a judiciously dosed chronic opioid therapy can actually hamper physical and cognitive recovery. We see this a lot in the hospital. We see this a lot in rehab and post-acute care, and even in long-term care, where there are providers, my former hospitalist colleagues would say like, well, I can't give that 90-year-old an opioid. My goodness, they just had surgery. Like, please give them an appropriately dosed opioid. Remember our rules of geriatric prescribing. So tiny doses, like 2.5 milligrams of oxycodone, 1 5 milligram tablet, or even less of hydrocodone. Those can actually be very appropriate. It's about balancing the analgesia need, the pain relief need, with the potential for side effects. I can give anyone enough opioids to make them comatose or have all sorts of side effects. That is not a problem at any age. It's about kind of finding that nice balance. And for older adults, the balance just happens at a much lower dose. I hear, this is usually the point in this talk where I hear someone ask, well, what about tramadol? This is my favorite description of all time, I think, of any drug, but particularly tramadol. And this is from a nephrologist who does a lot of palliative medicine for dialysis patients. This is from a podcast called The Curbsiders for back in 2019. So it's kind of showing its age, but it's still good. Tramadol is the sullen, unpredictable teenager who wore only black, sometimes kicked puppies, set fires. That is the child of codeine and Prozac put together. And that really is true. Tramadol is an opioid, so don't let anyone tell you that it's not an opioid. It is. It's a dirty opioid. And so what I mean by that is that it's going to hit the opioid receptors. It's also going to hit the serotonin receptors and the norepinephrine receptors. So it's like a dirty bomb that also sends all sorts of shrapnel out into someone's brain. It's actually formally been reclassified as a controlled substance in 2014. For a long time, it was not controlled and was described as a non-opioid, which we actually know to be false. False. For a long time, it was thought to be safer. There have been some really good studies, including the one that's referenced at the bottom here, that people taking chronic tramadol are actually at a higher risk of death from all causes than non-opioid therapies, and even some of the more traditional opioids like oxycodone. So long story short, what I tell people is for older adults, there are far safer options than tramadol. If you want to prescribe an opioid to an opioid naive patient, start with something else. There are other issues, like it's got active metabolites, meaning other chemicals that get unleashed as the drug gets broken down, that again, part of the dirty bomb. It also lowers the seizure threshold. So if you've got someone who's also taking antipsychotics, say for schizophrenia or bipolar disorder, those also lower the seizure threshold. So adding tramadol on top of that can actually be more risky from a seizure perspective. So I usually advise like, no. If we're gonna talk about opioid therapy, let's talk about a traditional opioid like hydrocodone, oxycodone, or hydromorphone. What about cannabis? So it sure seems like cannabis is everywhere now. And that is definitely true amongst older adults. There is a growing body of literature, including this great study from Pain, the journal Pain in 2018, that as cannabis has become more available through medical dispensaries and recreational dispensaries, its use amongst older adults is increasing. Our current crop of older adults are also, many of them are not cannabis naive. Many of them tried cannabis back when they were teenagers and in their 20s. So there is less stigma about using cannabis recreationally, but also for medicinal purposes in later life. So we've got a cannabis embracing older generation now. But the science that exists on the efficacy, how well it works, what are the side effects, what are the appropriate conditions, the doses, right, of different THC to CBD ratios, all of the questions that we have not yet been answered by the science. Hopefully, right, the machinery is starting to come online to really study this, but all the studies that exist now that have been published have largely excluded older adults, which is not helpful because older adults are commonly the ones that have more issues with persistent pain and more likely to want to use cannabis for medicinal treatment. And so when I talk to patients about cannabis and they ask me about it, I honestly say, we just don't know yet, right? The science is evolving. And so I can't give you really good advice about what to take, what to look for, what to ask for. What we do know is that it seems so far that CBD does have the more significant pain relieving benefit. So for my cannabis interested patients, it's getting easier to say, why don't you try some of the really good like purified CBD, broad spectrum CBD, and there's lots of different CBD subcompounds like N and M and all sorts of things. And but a broad spectrum seems so far to have the best efficacy. So that I will encourage because CBD doesn't seem to have the same side effects like dry mouth, nausea, vomiting, drowsiness. Can you hold on for 1 second? I have something that I need to deal with, but I will be right back, I promise.
We could go ahead and take like a 5-minute bio break. So if we want to come back at 10:15, that will give us 6 minutes to run and do a bio break. So Katie, we're gonna return at 10:15. Okay?
Perfect.
Okay, awesome.
Hey, Angela. It's Tyler. So it wasn't until this presentation that I realized why my doctor a long time ago pulled me off of baclofen.
It's good awareness.
Yeah, yeah,
And also showing the lack of communication, maybe.
yeah, yeah.
So
Yes, that is distressing to hear, but I'm glad that you were able to come off of it.
Well, I mean, it wasn't a daily dose. It was just when I had a particular incident happen, he told me to
Yeah.
take baclofen. And before that, I was going to the emergency room and getting injections of a high-powered muscle relaxer directly into the impacted body part. So,
Yikes.
yeah.
Well, baclofen does, like most things, it does have a role in short-term treatment, like after an injury, um, a twinge, right? A thing happened. We worry though when it becomes much more sort of persistent use, because little bits of a good thing can still be good, but a lot of a good thing sometimes is not. And
Yeah.
that can definitely be true here.
So I also dropped in the chat. What about for being prescribed things like meloxicam instead of opioids for people that can take NSAIDs? I know a lot of older adults can't, but
Yes.
uh, my grandfather towards the end of his life was prescribed a daily low dose meloxicam,
Mhm.
and my parents are currently taking that, and actually my doctor just started me on that regimen too.
So I generally love meloxicam. My dad took it for a while, and did really well with it. In general, the NSAIDs, ibuprofen, meloxicam, piroxicam, there's a whole diclofenac, there's a whole bunch of them, in pill form. I treat them like opioids. They have a place at the table for older adults. There are a lot of older adults that are taking blood thinners, aspirin, have kidney trouble, have ulcers that really can't take any NSAIDs because of the risk. But not all older adults are in that camp. There are a lot of older adults for whom a low dose, right, judiciously dosed, um, with good follow-up and management, it can actually be really beneficial for folks. That's not habit forming, doesn't have the same fall risk, as like opioids and muscle relaxers and gabapentin. Um, so yeah, I tend to like NSAIDs uh, for the folks with a lower risk profile.
Okay, thank you.
Yeah, yeah, no problem.
There's one more question. Cindy's
Oh,
asking if
great.
you'll be discussing pain pumps for older adults.
Oh, no, that could be a whole session in and of itself. um, Sadly, not today in this session, although if there really is an interest in amongst this community learning about pain pumps, I am probably not the right person, but I know folks up on the hill at OHSU in the Comprehensive Pain Center that do manage these for older adults and have actually implanted them in some of the geriatric patients that are seen on the hill at OHSU. So I can definitely recommend to the Angelas a potential speaker if it really is an interest.
awesome. Thank you, Dr. Jacob.
Yeah, of course. I have 12:17. So is it okay if I get started?
Oh, yes. Yeah.
Awesome. Okay. Yeah, thank you. There was someone at my door and I was sort of like, oh my God, they're just not going away. Okay, so coming back, we were sort of talking about drugs and the right time, the right place, the right type. Here's my general approach, and this is how most practitioners, most providers, prescribers are going to end up layering medication, in particular, and different interventions in ambulatory care. So up top, this is where we start with all patients, right? We want to determine what are we dealing with here. make a diagnosis if at all possible, explore the impact, right, on the other domains of life, function, mood, social health, quality of life, define what successful treatment would look like. So really identify the goal. Is it standing at the counter and preparing your meals? Great, we're going to work towards that. And use that as, we're going to use that as the check-in. So in follow-up and everything, we're going to come back to how are we progressing towards that goal of standing at the counter and preparing meals. And then again, start one and monitor, right? We start and stop one medication at a time with some follow-up in between visits. You are actually an important part of that follow-up. So because you are going to have the ability to see patients in their home, see patients in a different kind of environment. And you may even have some clients or patients that feel more comfortable telling you things that maybe they didn't feel as comfortable telling their doctor. And so don't overlook your role in this. Every provider has a slightly different approach to this, but in general, we kind of start with the least invasive and we go to the most invasive or most risky. Most of us actually like to offer something topical or kind of an oral NSAID for the right person, and Tylenol, which is like always our go-to, before we're going to recommend something like therapeutic exercise, PT, some sort of manual manipulation treatment. Because, and I can attest to this, when I had a rotator cuff injury, it hurt like hell to go to PT until I actually got like a week or so of Tylenol and ibuprofen under my belt. Older adults are exactly the same way. So if uh, we should be doing more of this, but for even if it's for a chronic pain condition, if the person needs like a week of ibuprofen or meloxicam, or even a week of an opioid to kind of ramp them up into physical therapy, that is perfectly fine and very reasonable. One thing you may have noticed as well is the difference between scheduling a time for a particular medication or leaving them PRN, which is as needed, Latin for as needed. PRN regimens only work when patients are willing and able to take them. And so what I mean by that is that when a prescriber prescribes something like, oh, just take it when you need it, right? And you can take it no more often than every 4 hours. I have had patients over the years where families came back to me and they said like, oh yeah, dad didn't take that. He never took it. I don't even know if he filled it. Right, it's that stoicism, or it's that like I don't want to get addicted to it, is something I've heard a lot in recent years, even with non-habit forming medications. And then the counter, the additional example to that is for our cognitively impaired patients. They may not have the executive ability, right? The planning, the kind of reasoning ability to remember and successfully take a PRN when it's appropriate. So there is a sort of right patient for a PRN regimen, but there are a lot of patients where you may actually, or they may actually benefit more with a scheduled dose. So those with dementia, those with other cognitive impairments, even those with like a situational pain. So if someone doesn't want to go to physical therapy or doesn't want to go to, I don't know, something, or they're backing off of like socializing with family or friends because of the pain, where they know ahead of time, right? They can anticipate what's coming. Then you might actually just schedule it and say, before you go to physical therapy, it's okay to take 2.5 of oxycodone before physical therapy, right? That kind of schedule. And so doing this may actually reduce overall usage, because instead of letting the pain get to sort of a screechingly high level where the person then has to take multiple at a higher dose in one swig, or multiple over time, you never actually let it get that high, right? So you never actually let it get to that screechingly high level where then people are taking more. So there is some benefit. There's some benefit to this. I wanted to switch gears entirely and talk a bit about non-drug therapy, because I think you all are in the best position to kind of reinforce this and even bring some of these ideas to your clients. The first is Tai Chi. So Tai Chi, for those who are not familiar, although I feel like it's become more available now, this comes from ancient Chinese practice. This is the practice of Tai Chi is something like 6,000 or 7,000 years old. And it has been used as a therapy in Eastern medicine for a very, very long time, but only in, say, the last 20 years or so have Western medicine really caught up and started studying in a more kind of scientific way um, the effects and benefits of Tai Chi on chronic pain, along with a whole host of other conditions. This graph is from a meta-analysis, so which is a study of studies, and all of the names and the years are different studies that were done for that particular condition. So you can see Tai Chi for OA, which is osteoarthritis, Tai Chi for low back pain, which is LBP, for osteoporosis, for fibromyalgia, and all of those names underneath are studies. They looked at the effect sizes, so what each study showed, and then put it all into a big mathematics machine to come out with the pooled effect. And that's what the triangles show. So the triangles here all fall on this left side of the zero, which actually shows that there is a significant benefit to Tai Chi over the placebo or whatever the control was in each of these studies. And so what we know from this is that Tai Chi works. This meta-analyses, these are the best studies when they're well done, and we have them because they really aggregate a lot of existing data. And so this was pretty earth-shattering for me. This tells me that I can and we should be recommending Tai Chi for a whole host of chronic pain conditions. I just showed you one study, but there's a whole boatload now that's showing benefit across the different sexes, across decades of life. So even older adults have been studied when it comes to Tai Chi and pain across different racial groups, and even compared to aerobic exercise. So traditional kind of cardiovascular exercise, Tai Chi is better. You can even do Tai Chi standing or seated. So for people that don't feel super confident in standing, say without a walker or without a cane, they can actually start in a seated position. And as they feel more confident, progress to standing. And there is a dose here that has really seemed to be kind of the ideal sweet spot. And that is 1 hour, 2 to 3 times a week, which I know seems like a lot. But even getting started with less than that and building up, finding ways through like DVDs, YouTube videos, which of course they're everywhere now, it's littered across the internet. There are ways to even build this into a daily routine at home. And I know I have seen patients that only go to class once a week and they feel like it helps them. So even though this is the studied dose, if someone's doing less than that, if they're getting benefit out of it, great. Works for you, works for me. This is an evidence map looking at all the studies of Tai Chi for all sorts of different conditions that broke it up to no benefit, unclear, and potential positive effect. And you can see pain is right here with the orange arrow. So we have solid evidence now that Tai Chi for pain works. Massage. This evidence base is not quite as evolved as Tai Chi, but it's getting there. This is one survey-based study from a complementary medicine journal, now kind of showing its age, that was a survey of older adults in Kentucky. About a third were over the age of 75. Older adult in some of these complementary medicine journals usually means over 50, which as I get closer to 50, I get a little offended to that. But, you know, what have you. All the users completed this survey, and you can see here on the graph, massage users in the past year are in black, no massage in the past year are in gray, and they looked at all sorts of different domains, everything from physical to emotional to social functioning to just sort of general well-being and health. And all across the board here, we saw significant, that's what the star means, significant improvements in all of the domains. And so considering pain is such a unique and personalized and individual experience, this actually does mean, this is meaningful to me when I see this. This is another study of studies, a meta-analysis looking mostly at younger adults. Admittedly, again, the evidence base here is still growing, but should we look for the triangle? The triangle here favors massage. So when we look at all these studies all together, massage really does seem to have a particular benefit. I know massage can be expensive. I know some things you can get medical coverage, particularly through Medicaid, I think, but not all diagnoses, and it can be a bit difficult to access massage, but there are more places now, like Massage Envy, which is a national chain that are all kind of all over the place, that will do things like sliding scale and medically targeted massage. And so it is a little bit more accessible than it used to be. And I think the hope is that it will become even more accessible to most, just like Tai Chi has. So when medications are misused, polypharmacy, which has a definition, but I won't bore you with it here. Too many drugs that are not benefiting the patient is really what it comes down to. Present in about 65% of all ambulatory visits for older adults. And it's easy sort of to see why when we think about the average number of medications that our older adults in Oregon are prescribed on an annual basis. It's a lot. Our older adults on average take about anywhere from 15 to 18 medications per day. This includes oral, over-the-counter, prescribed and non-prescribed, and topicals. So it is kind of a broad umbrella, but that is a lot of medications, and that is a lot of opportunity for intentional or unintentional misuse. I do want to clarify what I mean by misuse. When I use the term misuse, I am not talking about confusion about what to take, sort of honest and earnest, I don't understand what I'm supposed to do. Okay, that's not what we're talking about here. That's a whole separate thing. And then when cognitive difficulties are negatively affecting someone's ability to manage their medications, that is a totally different thing. We're really talking about some of the examples that are listed here in the middle of the slide. Doses greater than prescribed and or are necessary, taking longer lengths of treatment than are necessary. And this can definitely happen on both sides of the prescribing equation, from the provider and then just sort of independently from the patient. Using medications for purposes other than what was prescribed, hoarding doses, and then using it with alcohol, other medications that are not prescribed. We sort of think about misuse transitioning into abuse when there are sort of life consequences, so social, legal, even medical consequences of that misuse. And so misuse in particular is very hard to measure, but is estimated by this study evidence brief back in 2020 to be present in about just under 3 million older adults. And that's probably an underestimation. Older adults in particular are at a unique risk here. There is more vulnerability amongst older adults because of just a perfect storm of potential risk factors. So they tend to be exposed to more prescription medication. Understandable. They tend to have higher symptom burdens, meaning from different diagnoses like heart failure or pulmonary disease, GI disease, autoimmune conditions. Older adults tend to just experience more symptoms, pain, nausea, the yucks, just general like malaise, fatigue, poor sleep, right? A lot of those can really plague older adults. And then, of course, changes in drug metabolism, right? Older bodies, not the same as younger bodies. All of that together sort of creates this toxic stew that can really put an older adult at greater risk of medication misuse. What we know about medication misuse is that there are some risk factors that do bump people into kind of a higher risk category, and it's those that are female identifying. We know too, actually, aside from this, that females do tend to get prescribed more medication by their providers. And they do tend to get prescribed inappropriate medications more commonly than men. So that may actually be part of this, it's a dyad issue. It's not necessarily just being a female means that you're likely to misuse your medication. It may be that they are even more exposed to medication that can be misused by their providers. Concurrent loneliness. So remember, loneliness and isolation, not the same thing. Some people are perfectly happy being lone wolves and being relatively isolated. The loneliness, the best description I've heard is the desire for more relationships and social engagement than you have access to. Depression, and that, which of course seems to plague women of all ages, females of all ages, and then any sort of history of substance use disorder, even if it was earlier on in life. And when we think about SUD, actual diagnosable SUD, the latest measurement has been about 1 million older adults that live with a substance use disorder. I would argue this too is a gross underestimation for reasons we'll talk about right now. The prevalence of alcohol use disorder, opioid use disorder, both illicit and prescription, sedative and benzodiazepine use disorder, even cannabis use disorder, rising for older adults. The pandemic in particular really sort of knocked older adults for a loop when it came to substance use. It wasn't just 30 and 40 something sitting at home drinking cocktails. It was a lot of older adults as well. There's a strong overlap here with depression and suicidality. Older adults actually, older men in particular, are much more competent at completing suicide. So attempts tend to be more common in older females. Completed suicide tends to be more common in older males. And we know over the course of the lifespan, people seem to, quote, learn the more effective ways to actually commit suicide. So this suicidality in particular is a huge issue for our older adults. One of the reasons I think the documentation, the documented numbers of SUD amongst older adults is low is because this does not always capture those older adults that are in remission later in life. So remember, all of us, by the time we get to 80, 85, 90 years old, we have had 80, 85, or 90 years of life that we lived. Many people that make it to that age, if asked, will say, I had an alcohol problem when I was younger, when I was working, but I haven't had a drink in 20 years. That is AUD in remission. And those diagnoses rarely get captured through some of these database and like Medicare claims data studies. There are also lots and lots of older adults that were using illicit drugs in their younger years, heroin, stimulants, all sorts of things that may actually still have some vulnerability, right? So if they, had a history maybe decades earlier of using heroin and were able to go through like, NA or, quit cold turkey, them being exposed to a prescription opioid later in life can actually be a big trigger for these folks. So there's a lot of murkiness here in the data, and there's a lot of risk for relapse out there that can be sort of triggered by the medical system, both with being prescribed benzodiazepines later in life and then opioids later in life as well. Not to mention that the world just seems to be coated in methamphetamine and fentanyl these days, and older adults are certainly not immune from slipping back into illicit drug use. Then we make it even more complicated, which is the person with a substance use disorder, either in remission or active, that also has chronic pain. I'm betting that these are some of the most challenging patients that you all work with. I know these are often some of the most challenging patients I work with. And so just know there's no easy answer here. These cases are always difficult, always complicated. And so setting clear goals and priorities is always going to be helpful. Acknowledging the complexity of treatment decisions in this context is also really important. So someone, the older adult who started using alcohol again, or for the first time, who was also taking regular Tylenol. That is a liver atomic bomb. So we worry about that. What if that person also starts taking ibuprofen? What if they're taking alcohol and gabapentin together, which work on the same receptors in the brain? This can get very, very, very complicated very quickly. And so in a perfect world, this is where we as a healthcare team, a big, broad healthcare team would come together and work together to decide what are reasonable options. Is the patient even capable of participating? Are they cognitively or communication able to really engage in this decision? But the more teamwork you're going to be able to get from the healthcare team, I think the better generally it is for patients. So let's talk a bit about treatment planning. Successful care planning for people with chronic pain, plus mental health issues, plus minus substance use disorder conditions. So the whole big knotted up ball of twine here really does depend on attending to all the concurrent issues together. You cannot just focus on one at the disfavor of the others, because it's like a game of whack-a-mole. The minute you focus on one gopher, the other gopher's gonna come up. And so you have to use our twine metaphor, you have to pull on all the loose ends in order to really help that patient kind of right the ship. And so teamwork, again, is going to be your friend. Use all of the members of the team. Remember, you may not want to go directly to the physician or the provider. You may want to engage the social worker, their outpatient social worker. You may want to engage their care manager, the RN that works with that provider, right? Get your posse together and kind of bring people in. Because the goal here is to craft a management plan that addresses all of the drivers, right? We need to attend to the physical, the mental, the social, and the environmental and contextual drivers of both the pain and the SUD and the mental health issues. Success really does rely on the communication, which I know all of you are probably saying, I don't remember the last time I got a doctor on the phone. And I'm with you. I hear that from my therapist all the time. It is not easy, and I'm not going to pretend that it is. It doesn't mean that we should stop trying. Setting and reiterating those clear function-based goals, and then regular follow-up with check-ins. So when you are connecting with your clients that have conditions at the intersection of all three of these, check in on all of them, right? Make sure that you're not focusing just on one gopher, you're focusing on all the gophers. And then document. Repetition is your friend. I know sometimes as a specialist, even though PCPs don't ask me for my records, sometimes I just send them anyway, in sort of a Oregon passive aggressive show of force. Because if it's sitting in their mailbox or if it's sitting in a nurse's queue, then I've done my job and somebody else might actually read it. And you never know. I also want to acknowledge, now that we're coming to the end, that this is really hard work. There is no perfect answer. There is no perfect solution. There's no recipe. Unfortunately, every situation is different. But because every situation is different, every situation is an opportunity for some creative thinking, which I don't know about you all. If my practice was boring, I would retire. I would go do something else. But this work is never, ever boring, right? It is always interesting. It is always sort of ripe for creative problem solving. And that at least is the invitation to a really exciting day or exciting week. So I have 10:42. I would love to hear more thoughts, questions, wonders, worries. I know hopefully I was answering everything as it was coming through, but if there's more thoughts or discussion points, I'd love to hear them.
Yes.
Thank you all so much. I know this is a long talk, so thanks for hanging with me.
Yeah, thank you so much, Dr. Drago. It's been great. Joyce asked, how do you feel about cortisone injections for pain?
Love them. Yeah, love them. If particularly for shoulder bursa, so like trochanteric, hip bursa, shoulder bursa, like rotator cuffs, even spine, spinal steroid, epidural steroid injections, hips. I know ortho and rheumatologists will even do them in ankles and elbows and stuff for folks with, complex tendonitis or inflammatory arthritis issues. I think every patient should at least be considered for them if they have, a potentially amenable condition. We do worry a little bit about folks with diabetes, particularly with bursa injections, just because the steroid can actually sort of leak out and can actually cause a rise in blood sugar for a few days afterwards. But I personally have injected, done cortisone injections for diabetic patients and just said, we need to pay attention to your sugars for the next few days, week, and then it usually comes back to normal. So unless you've got a really brittle, very delicate, insulin dependent diabetic, it's usually fine.
And then Tara is asking if she said that she heard you recommend therapy. Are there certain kinds of therapies that you feel are more effective, like CBT?
Ooh, good question. So my understanding of the evidence is that CBT can definitely be helpful, but it is not the only helpful modality. Um, I think mindfulness therapy as well, so mindfulness-based stress reduction. There's even some pain-specific mindfulness training and therapy that has some really good evidence behind it. And honestly, I think mindfulness is almost kind of edging out CBT for chronic pain because it really focuses on helping people accommodate what their body is sort of telling their brain and what their brain is telling them about how their body feels, and just acknowledge and sort of turn down the volume. Oh, I love that somatic experiencing therapy. There are a lot of different options out there. And so I don't believe that one is any more correct than the other. I think it's about the person, what's going to be sort of the most tolerable and most acceptable to them, and then maybe even trying a couple of different approaches. And if one doesn't work, trying something else.
And then Shauna commented somatic experiencing therapy. Any thoughts there?
Um, I sort of stick to like it's in the toolbox, right? My knowledge of, the kind of ins and outs of somatic experience therapy could probably be better. So uh, if there are experts here that have had more experience with it, I'd love to hear from you. Um, but I've always put it in the same camp as mindfulness. That sort of like be present, right, and just observe, non-judgmental, right? Kind of turn down the catastrophic thinking, all of that, and accommodate. Um, and I know, at least from that perspective, that the science does say that that works. It may not be perfect for everybody, but it's a tool in the toolbox. Oh, EMDR.
Yes, and Cindy commented, anyone have experience with EMDR working for chronic pain?
I know I have not. I have not yet, but I wouldn't be terribly surprised.
This is Cindy, me either. I'm going to research it because that just popped into my head. I haven't seen it work. I mean, I haven't had anybody tell me they had success with it for that particular issue, but it seems like there would be a great link for that to work.
Oh yeah, especially with the overlap between traumatic life events, particularly adverse childhood events,
Yeah,
and later development of medical conditions and chronic pain. I wouldn't be surprised by that either.
I'm going to dig into it. And thank you. This has been absolutely fantastic. Appreciate you.
Oh, good, good. It's my pleasure. I really hope there were some beneficial little pearls in there for you. You guys have very, very difficult jobs. So anything I can do to help make it a little easier.
And
Dr.
then-
Drago, I have a quick question for you, kind of going back
Mm-hmm.
to the dietary change question that I had.
Mhm.
Part of why I raised that is a while back, when I started into the field around pain management, I noticed a disconnect between dietitians and physicians,
Yes.
prescriptions related to pain management. So physicians were prescribing a pain management regime that stripped a lot of essential nutrients from the client's diet, but they weren't being explained how to add those back using supplements or changes to their food. Has that changed at all, or is that still kind of one side's not talking to the other fully? Because in I started bridging that gap from having to learn how to change my diet based on prescriptions I was taking from my own angle.
Yeah.
And then I just launched into this field. And so I was talking to people about some of the literature coming from registered dietitians and nutrition therapists to combat the pills that they were being prescribed that were stripping nutrients that they needed for the pain. So
Yeah.
no headwind has really been made there?
Unfortunately, no. The sort of right hand not talking to the left that you described still very much true. Unfortunately, in most practices, even on the Hill at OHSU, there is more embedding of dietitians into different specialty practices. It hasn't really yet penetrated the world of chronic pain. And in primary care, nope, there is no presence of a dietitian, and primary care providers, as we get trained and when we do CME trainings and such like this, there has just been so little presented to us or really brought to the table about diet. Part of that is just that the evidence, the medical evidence that we look for hasn't always been there. This too may be a case of like the dietary, the world's not talking to each other, that like dietary literature is just over here and physicians are over here. But yeah, the gap really does still seem to be there.
And then Tara shared a link in the chat, organpainguidance.org. So,
Yeah, there's some great materials that have come out from the like Oregon Medical Association, Oregon Pain Guidance. I've looked at this education toolkit. It's great. There are lots and lots of other open source materials on chronic pain, what it is, how it changes the brain, and kind of alters perception and sensation throughout the body. I didn't get into any of that because I thought it would be a snoozer, honestly. But it's all very fascinating how particularly the neuroscience of it and the rewiring of the brain to basically make everything painful after that. And so I found that kind of guidance really helpful when I sit with patients as they're like, oh my God, I feel like I'm gonna die. Why is it like this? And I can actually now sit and say, your brain has rewired. Like, this is not you, it's your brain. It's the electrical conduit in your brain. And that often gives patients a lot of peace. Knowing that like it's not a psychic problem, it's not them being weak-willed or anything. It literally has rewired your brain.
and
Oh
then,
boy. Yeah, Ginny, I've got the chat up here since I took my
great.
slides down. Oh boy. This is very challenging. Very challenging. This is someone actually that I might even think about EMDR. for her if she has a trauma history, and just purely to focus on that like biofeedback with breathing, um, and even some mindfulness therapy. It's going to take a bit of time, I think, to get her over the hump and to like open her mind and try, because people who have been exposed to or use benzodiazepines for anxiety for years, it can be very, very, very difficult to acknowledge that like this medication may not be best for me in the long run, and maybe my body now is not handling it as well as it did 20 years ago. That can be a really, really big hill, to climb over conceptually. Um, and then, of course, like there's anger with the provider too, feeling maybe like the rug was pulled out under her. That's a lot of trauma in and of itself. But I would, I think that's the kind of coaching, that is going to be necessary. And I like to take it out of the provider's hands and the client's hands by saying your body is just not the same as it was before, right? Physiologically, right? The machinery is different. So even if I have no doubt that lorazepam really helped her for a good chunk of her life. Now though, it and I kind of fudge this, like your body is probably not processing it in the same way that it was before. So just like your style changes, your hairstyle changes, right? Your makeup changes. As you get older, your medications change too. And the way you manage particular things just needs to change. And that's true for all of us. Nonverbal signs of pain. I don't think it's online anywhere, but you all are going to get the slides sent out to you with the follow-up emails. So please, please take that, print it out, put it up, do whatever you need to do with it. These are all open source. You could probably even Google. I've given some of this talk before, so you could probably find it on Google Images, but you'll definitely get it in the follow-up email. Oh boy. Yeah, Kim, see, this is the hump, right? This is the resistance. Um, I My personal approach is to just sort of sit, be with people kind of in their resistance until they kind of come to it naturally, saying like, I don't want to be angry anymore. Um, my personal philosophy as a physician has always been that my job is to advise and guide. And I think that's true of all of us, really, right? Our job is to offer the best advice that we possibly can. We cannot always make our patients take it. Um, what I will tell you is that seeds do get planted. So your discussion, and bringing up that like there is another way, right? There are other ways to manage this. Um, that seed is in there. And so even if now she's just not ready to, she wants to be angry, and I know that feeling, um, uh, that seed is still in there. And so it will grow at a certain point, and that's when people come back and say like, "Hey, you mentioned this before. Is that still an option?" Um, Oh God, hydroxyzine is an absolute no. I didn't bring it up here. It has no basis in treating pain. It also has no basis in treating anxiety. It's Benadryl. Yeah, it's Benadryl by another name, basically. It's in the same family as Benadryl. It will cause her to fall. It will cause her to become confused. It will cause all sorts of bad stuff. For some reason, and I don't know what happened, but in the state of Oregon in the last couple of years, the entire world of primary care and general medicine discovered that hydroxyzine exists. And so everyone prescribes it now for sleep trouble, anxiety, worry, all of that. But it is Benadryl, which is a very, very bad drug for older adults. If she's not having any of those issues now, where you're seeing, or she's complaining about like, I don't feel right, I feel fuzzy, my balance is off, you might want to focus still on like sitting with her anger and just acknowledge like there are too many problems, I need to focus on this one right now. um but keep your eagle ears, your bunny rabbit ears open, that if she starts to mention or seem confused, off, imbalanced, talking to you about issues or having actually fallen, you can bring up to her that like that medication, I have heard that it can cause those things, and maybe then put in a word to the physician. But right now, I would probably just be her buddy, an advocate, and like acknowledge the anger, sit with her, wait for those seeds to sprout. God, these cases are always so miserable.
Yeah. Thank you so much, Dr. Drago. I'm gonna throw up our trainings that are coming up. Maybe, there we go. And I just want to thank you so much. So much good knowledge and information and just willingness to answer people's questions. Yeah, so thank you, thank you, thank you. And I just want to let people know that we have more Gero competency workforce trainings coming up in June and July. We're taking August off, and then we will be back in September with a training on the Declaration of Mental Health Treatment. So our psychiatric advanced directive with Dr. Avila. Okay, well, thank you so much. And we will send that follow-up email. And we look forward to seeing everyone again in the future. Thanks.
Thank you all very, very much. Again, I'm so honored to that you elected to spend your morning with me. So
Perfect.